Okay, tumra 1, 2, 3, 4. This 4 people question will be on placenta. ঠিক আছে? হ্যাঁ, আগে তুই বল. What is this? Examiner and question they will ask like this, the way I am asking. Okay. Huh. This will be a একটু লাউড ये মাইক আছে, এটাই আছে.
It is a formalized mounted specimen of placenta with membrane and umbilical cord.
Okay, very nice. So this will be a viva question for you. Okay, this will be in viva table. Specimen carries 10 marks. Maximum they will ask 5 to 10 minutes only. One specimen. Okay. So first thing is you have to identify the specimen properly and you have to name the specimen properly. She has identified very properly. Okay, you describe the specimen now. She has told it is a placenta. Tell what you know. If it is wrong, we will correct.
It shows fetal surface one side and maternal surface other side.
Okay.
And there is a 2 umbilical cord.
2 umbilical cord. Okay.
And shiny fetal surface.
See, when you describe placenta, you will say the size, shape, surface. Okay. It is a discoid in shape because it is disc shape. Okay. It is hemochorial. Hemochorial means the chorion of the placenta is in constant touch with the blood. Okay, and it is deciduate. Why do we call it deciduate? Because it expels from the uterus. Okay, what is the weight of the placenta? 500 grams. The amount of blood inside placenta is 500 ml. Okay. Okay, you have told which is the fetal surface, which is the maternal surface.
Shiny is the fetal surface.
Shiny, shiny membrane ache. See this one. Okay, this is the fetal surface. The rough surface is the maternal surface.
Fetal surface.
It is the two placentas are together, so you can't say. Okay, the rough surface is the maternal surface. Smooth surface covering by the membrane is called the fetal surface. How is where does the placenta separate? Decidua? No, और specifically बोलते हो. Thanks. No. See, pregnant endometrium, it has 2 layers. This is functional layer. Decidua functionalis. This is decidua basalis. Okay, this is deep layer, this is superficial layer. The zygote, it will get attached on this layer, decidua functionalis. Okay, this decidua basalis has 3 more layers. Superficial spongy layer, superficial compact layer, middle spongy layer and basal layer. Okay, the plane of separation of placenta is this. Placenta will attach till this. Okay, niche mane the cleavage plane. When placenta separates, it will separate between the spongy layer and the basal layer. Okay, what is Nitabuch membrane? You only told. Nitabuch membrane importance टा की. What is the importance?
Placenta invade हो जाता है.
हाँ, surface. See, এই দুটো লেয়ারের মাঝখানে there is a layer. It is called Nitabuch layer. Nitabuch. Okay. ঘুম পেয়ে গেছে তাড়াতাড়ি। See, when placenta gets othered, no? Placenta যখন এই layer কি করবে? It will prevent the penetration of the placenta inside this. Okay. What does, if this Nitabuch layer is absent, এটা যদি না থাকলে কি হবে? This placenta will go here. What it is called? Placenta accreta spectrum. PAS. Placenta accreta spectrum. It comprises of what and all? Accreta, increta, percreta. What is accreta, bol? Bol taratari. See, when this placenta is attached to the, see, this is myometrium, endometrium, myometrium, this is outer serosa. Okay, when the placenta, normally it will be present above the basal layer of the endometrium. Here, if it will go and attach to the myometrium. This is called accreta. If it invades the myometrium, we call it increta. Increta, invade. Okay, percreta, it will pierce the serosa also. P for P, pierce. Okay, it will pierce the serosa. Samne, what will be here? Here there will be bladder. Here there will be rectum. Okay, if the percreta is other to the bladder, okay, it will, we can't deliver the placenta only. Imagine after delivery we have to, the placenta will get separated. Okay, in this case adherent placenta will not deliver. In that case we have to do hysterectomy and remove the placenta. Intact hysterectomy we have to do. Okay, this is called obstetrician's nightmare. Obstetrician's nightmare. Okay, from the fetal surface to the maternal surface, what are all the layers in placenta? No, whatever you say.
Amniotic membrane, chorionic plate, choriodecidual space,
Yes, very good.
decidua,
That's all decidual plate. A, B, C, D. You remember A, B, C, D. A for amnion. Okay. We forget B. C for chorionic plate. D for decidual plate. In between C and D, there is a space. Chorio, decidual space and villi. So from the fetal surface to the maternal surface, these will be present in the placenta. First there will be an amnion, okay, there will be a chorionic plate, there will be a choriodecidual space with villus, then there will be a decidual plate. How is the placenta formed? How is placenta formed? Bol. Embryology of placenta. 4/5 is from fetus. 1/5 is from mother. Placenta. This fetal component is called what? This is called decidua basalis. This is chorion. Sorry. This is deciduous bacillus, chorion frondosum. Chorion frondosum. Okay. See, this is the zygote. Okay. This part is called the chorion frondosum. This black color. This is chorion frondosum. This part is deciduous bacillus. This part is called chorion leve. This is parietalis. ठीक है, but you should know this. How does the placenta is developed from which part? So fetal part is chorion frondosum, maternal part is deciduous bacillus. Okay. Okay. Tell me the functions of placenta. तुम रखी हो जन बोल functions of placenta बोल. Nutrition, excretion. See, I will give you a very good mnemonic. You will never forget. Okay. Okay. It has nutritive function. B for barrier. E for excretory. Enzymatic function. Then expiratory. Respiratory. No, this is not expiration. Excretory, enzymatic, exocrine. Nutritive function, barrier function, excretory function, enzymatic function, exocrine function, respiratory function. बोले दिबी तो हाँ भूल भी ना तो हाँ एक्सोक्राइन exocrine means it will secrete hormones. Okay, next this is the question. What are all the hormones secreted by placenta? हाँ बोलो. There are steroid hormones. There are protein hormones. बोलो. Steroid hormones की क्या है? Estrogen, progesterone. Protein hormones? HPL, human placental lactogen. तारपर human chorionic gonadotrophin. तारपर human chorionic thyrotrophin. तारपर ACTH, adenocorticotrophic hormone. Then what is PAPA? Pregnancy associated plasma protein A. Yes, pregnancy associated plasma protein A. Pregnancy specific beta globulin. So what you get এখানে একটা mnemonic আছে happy HAPPY. ঠিক আছে? Okay, now we will see the abnormalities of placenta. What is the normal weight of the placenta? তো আমরা বলেছি. What is the normal thickness of the placenta? When will we call there is placentomegaly?
More than 4%.
So what is the normal size of the placenta?
2.5.
Normal thickness of the placenta at the center. At the center is 2.5 centimeter. Okay. So if it is to, if it is more than 4 centimeter the thickness, we call it placenta-megaly. If it is less than 2 centimeter, we call it small placenta. When placenta will be big, when placenta will be small? Yes, when baby is big. Huh? Macrosomia, diabetes mellitus, GDM. Then, why GDM has placenta-megaly?
Insulin-like growth factor.
What does it do? जोरे बोलो, let everyone listen.
IGF की वजह से ज़्यादा
শিবামি বুঝতে পেরেছিস ও কি বললো? মাইক কই? ইউজ দ্য মাইক এন্ড সে। আমি ওকে জিজ্ঞেস করব।
insulin like growth factor की वजह से
What does insulin like growth factor do?
more growth
It causes hypertrophy and villus edema. Okay, hypertrophy and villus edema. So the placenta becomes big. Okay. Then maternal anemia, torch infection. In these conditions, there will be placenta-megaly. Small placenta. When will you have small placenta? When the baby is small. IUGR. Preterm. ঠিক আছে? Abnormal placentas. Placenta succenturiata. What is placenta succenturiata?
one extra lobe is
So there is a placenta plus placenta kache or ekta accessory lobe ache, and this accessory lobe is connected with blood vessels. This we call placenta succenturiata. What happens after delivery? This placenta is expelled out, but the part of placenta, this small lobe, remains inside the uterus. That will cause PPH. Okay, or retained placenta. This is called placenta succenturiata. Then placenta bilobate. What is placenta bilobate? When there are equal size of placentas connected by vessels. Placenta spuria. এখানে একটা বড় প্লাসেন্টা আছে, কাছে আর একটা ছোট প্লাসেন্টাল চাঙ্ক আছে, but there is no connection of blood vessels in between. Preterm. সবাই ভালো করে লিসেন কর, ক্লাসের শেষে আমি মানে কোশ্চেন জিজ্ঞেস করব। প্লাসেন্টা স্পুরিয়া. What is circumvallate placenta? What is circumvallate placenta? This will be a question for you.
fetus is thick and there is a deep between the fetal and the maternal.
See, normally this is the placenta. This is what? This is what? This is the chorionic plate. This is the decidual plate. Okay. Normally this chorionic plate is equal to the decidual plate. Okay. But in circumvallate placenta, what happens? There is an amnion layer followed by a chorion layer. Okay. The membrane. What happens? It will cause a fold here. Okay. So it will appear like a rim. এখানে কর্ড আছে, কর্ড থেকে ব্লাড ভেসেলস আসবে। ওকে, we can see blood vessels till this margin. After that the blood vessel will get disappeared. Okay. Then because of this fold, no, there is chance of fibrin deposition beneath this fold. Folder niche blood RBCs get clot, there is formation of fibrin. This fibrin deposition will cause infection, IUGR, preterm delivery. So 3 points you have to remember. In circumvallate placenta, chorionic plate is less than decidual plate. This is shorter. This will be the chorionic plate. It is shorter than the decidual plate. There is a fold of amnion and chorion. Okay. There is formation of fibrin. Fibrin which will lead to infection, IUGR and preterm delivery. This is circumvallate placenta. What is circummarginate placenta? This is circumvallate. Circummarginate. আমি যে কোশ্চেনগুলো বলছি note it down. What is circummarginate placenta? In circummarginate placenta, this fold will not be there. Just there will be a rim. Thickness, peripheral thickness will be there, but there is no fold. ঠিক আছে? These are abnormal placentas. These are abnormal placentas. Now we will see abnormal attachment of cords. Normal umbilical cord length কত? Umbilical cord. It is 30 to 50 centimeter. Okay. If it is more than 50 centimeter, see if it is more than 50 centimeter, what will happen? The baby will be like this. Okay. This cord will roll around the baby's neck. This is called nuchal cord. Nuchal is neck. Cord around the neck. Okay, because if there is cord around the neck, there will be fetal distress. Blood supply to the fetus will get hampered. Fetal respiration will be hampered because it is constricting the neck. Okay, and there is something called knot. See, eto bodo placenta ache. Okay, what will happen? The baby will move like this, like this, like this, like this, like this, and come, and there will be formation of a knot in this placental cord only. Okay, knot, there will be a knot. जैसे हम टाई करते हैं ऐसे knot form हो जाएगा. Okay, usually this knot is not a problem. Okay, because there is something called Wharton's jelly. Wharton's jelly, what does it do? It will protect. How many arteries are there inside placenta? Umbilical cord? Kota artery আছে, kota vein আছে. Umbilical cord এর দুটো আর্টারি একটা ভেইন আছে, 2 arteries and 1 vein. Okay, মাঝখানে there is some jelly substance. It is called Wharton's jelly. It will prevent the friction or constriction of these vessels. Okay, so when there is formation of knot also, that is not a problem because this Wharton's jelly will protect. Okay, normally the placenta is attached to the center of the cord is attached to the center of the placenta. When it is attached to the periphery, what do we call it? We call it battledore placenta. Okay, battledore, BATTLE, battledore. Battledore placenta clinical significance টা কি? Umbilical cord যদি periphery attach হলে কি হবে? There is more chances of avulsion. Cord avulsion or chance বেশি আছে. Okay, and if the placenta is down, baby's head is coming down. Okay, there will be chances of cord prolapse. Cord will prolapse before the baby's head is coming out. Okay, this is uterus. এখানে placenta আছে. This is the cord. Okay, baby মাথা এখানে আছে. Okay, cord এর আগে baby মাথার আগে cord আছে. If this cord comes out, we call it cord prolapse. How much the head is descending, more contraction happens, the more. ठीक है, this is battledore placenta. Okay, there is velamentous insertion of cord. What is velamentous insertion? Instead of this periphery, only there is a membrane and the cord is attached to the membrane. Cord is attached to the membrane, then to the placenta. This is called velamentous insertion. ঠিক আছে? Okay. Tell this. What is this specimen? Identify this specimen. কেউ একজন তাড়াতাড়ি বল। Tell.
This is a mounted specimen of the uterus along with the cervix, the fallopian tube, the ovary, and a cut section is made in the anterior part which shows the grape-like vesicles which are age-bound.
Okay, very nice. Okay, how are you saying this is a H mole? Because we can see grape-like vesicles. Okay, what is Hydatidiform mole? What is H mole? Define H mole. What is molar pregnancy? It is a abnormal conception, abnormal pregnancy. Okay, it has two features. Bolo keyo ekjon?
Complete and incomplete.
That are the types. Hydropic swelling of villi plus trophoblastic proliferation. See, molar pregnancy is an abnormal conception, abnormal pregnancy with hydropic swelling of the villi and trophoblastic proliferation. Okay, what is trophoblast? What are trophoblasts? See, when you see after the fertilization, there is morula, 16 cell base. Okay, morula te ki hoy? Next stage is blastocyst. There is a outer cell wall, outer cell mass, then inner cell mass. This outer cell mass, no, this is the outer cell mass. This outer cell mass will form the trophoblast. Two types of trophoblast: cytotrophoblast, syncytio. Cytotrophoblast means it has the cell wall. Syncytiotrophoblast means it doesn't have the cell wall. Okay, so it will be like this. This is the syncytiotrophoblast. This is the outer layer of the cytotrophoblast. There is cell wall here. এখানে cell wall নেই. Just it is like an amoeba. Okay, it doesn't have cell wall. This syncytiotrophoblast will produce beta HCG. All the hormones, most of the hormones are produced from the syncytiotrophoblast. This trophoblastic proliferation occurs in molar pregnancy. Okay, because of this trophoblastic proliferation and there is swelling of villi, this will form grape-like vesicles. Okay, most important feature because of this trophoblast produces beta HCG. No, most important clinical feature is what? Most of the patient presents with hyperemesis because beta HCG causes it mimics what? It mimics thyroid. Okay, it triggers the vomiting center. Okay, so patient feels presents as hyperemesis gravidorum. Okay, and normally in pregnant patients, if we do beta HCG, maximum it will be 40,000 only. But in molar pregnancy, initially only there will be 1 lakh because we have the proliferation, and this patient presents as thyroid storm also. Why? Because of the proliferation. HCG will mimic TSH. Okay. What are the types? Complete and incomplete. What is complete? What is incomplete? Differentiate between complete mole and partial mole. Now, आगे एटा बोल. How is complete mole formed? Partial mole formed. बोल. Two sperms will. See, 85% there is androgenesis. Most commonly it is complete mole only. Okay, in complete mole 18% is androgenesis because of androgenesis. What is androgenesis? There is duplication of a single sperm. There is an empty ovum. Okay, empty ovum means it doesn't have any chromosome. There is one single sperm. 23X. Okay, this will go inside the ovum. It will duplicate. 46XX. Okay, this is androgenesis. 15% will be caused because of dispermic fertilization. Dispermic fertilization in empty ovum. So there is an empty ovum. There are two sperms. 23X, 23Y. It will go inside 46XY. ठीक है? Partial mole is because of what? Two spermic dispermic fertilization in a complete ovum. So here 23X is there. Here 23X is there. It can be 23X or 23Y. So the result will be 69XXX or 69XXY. Why do we call it complete? Why do we call it partial? Completely meaning completely it has only vesicles. Okay, there is no fetal part or RBC. And completely only moles are there. Fetal, fetal part থাকবে না. আমি ওটাই বলছি. আমি কি বলেছিলাম? So complete will have only moles. Partial will have the fetal tissue plus RBC plus amnion. Okay, this is the basic difference. If you see the clinical features, no, ekhane the amnion layer is there. Okay, amnion is a protective layer, so proliferation will not be that much. Ekটু কম হবে. Okay, so the size of the uterus, no, it will be same to the period of gestation, equal to period of gestation. Here the size of the uterus is more than the period of gestation. Understood? Here in partial, because of the amnion layer, amnion আছে, okay, so যতটা proliferation হলেও, okay, it will be in the same size only. So if it is 12 weeks uterus, parabdominally also we can see it is 12 weeks uterus only. But here we can see parabdominally it is 20 weeks uterus. But by period of gestation it will be 12 weeks only, because there will be more proliferation. Okay, here there is 15 to 20% chances of GTN, gestational trophoblastic neoplasia. Here 1 to 5% chance. More chances of neoplasia, less chance. Here we have to give chemotherapy, there we need not give chemotherapy. Okay. Okay, how a molar pregnancy will present? Three balls.
Something coming from per vagina.
Something. What something?
Grapes like.
Okay.
Grapes like there is bleeding.
There will be bleeding. Then
Excessive vomiting.
Excessive vomiting. You missed one very important thing. It will mimic a pregnancy. Okay, there will be a period of amenorrhea.
Pregnancy.
We will doubt it as a pregnancy. Okay, there will be a period of amenorrhea. কিছুদিনের periods হবে না patient এর. That is the most important clinical feature. Okay, so amenorrhea, abdominal pain, vaginal bleeding, passing of grape-like vesicles. These will be the clinical features. And added features you will have hyperemesis, shock, perforate. This may perforate also. It will present as shock, or this grape-like vesicles will go inside the lungs, pulmonary artery, and it will present as embolism also. Hemoptysis can also come. Okay. What is the most important investigation? How will you investigate a case of molar pregnancy? USG, then USG, then beta HCG. What will you see in USG? Snowstorm appearance. What are the other conditions in which you see snowstorm appearance? Incomplete abortion. Then okay, you see this. ঠিক আছে? What is the treatment of choice for molar pregnancy? আমি বল, একটা মোলার প্রেগন্যান্সি এলে আমরা কি করব? হিস্টেক্টমি, স্ট্রেইট আবে ইউটারাস তুলে দিবি? You will do suction evacuation. Suction evacuation. Okay. After suction evacuation, you have to follow the patient with beta HCG levels for 6 months. কেন আমরা ফলো আপ করছি বিটা HCG নিয়ে? Because there is 15 to 20% chances of transformation into neoplasia. Okay, so we have to follow every patient for 6 months. If there are 3 negative values, consecutive 3 negative values, then we will reduce it to 1 month. Sorry. One beta HCG per month. For 6 months we have to follow. In 6 months there are 9 weeks. Okay, in that 9 weeks, any first 3 weeks which is negative, okay, we will stop it. Then we will monthly follow the patient. If the monthly also, if we get negative, then we will stop. If in any case, if we get rising beta HCG, suction evacuation হয়ে গেছে, then আমি মানে beta HCG repeat করছি. If it is more than 1 lakh or if it is more than 2 lakh, beta HCG is increasing. Then what we will do? Hysterectomy. Then we will give chemotherapy. What chemotherapy we will give? We will give methotrexate. Methotrexate on day 1, 3, 5, 7. Okay, plus folinic acid. Folinic acid we will give on day 2, 4, 6, 8. Folinic acid, what is leucovorin? Leucovorin is folinic acid. This is the chemotherapy. Hysterectomy, when will we do hysterectomy in molar pregnancy? When patient's family is completed, when she doesn't want uterus, when there is intractable bleeding, when we can't stop the bleeding at all, okay, and when we suspect invasive mole. Invasive mole is a type of neoplasia, gestational trophoblastic neoplasia. Fibroid, that's all. Take the mic and answer.
This is a mountain formalized specimen of uterus. Uterus showing fibroid.
What I ask is this: what is this? Okay, tar theke beshi when you commit, you will get caught. Okay, you will say this is a mounted specimen of
Specimens of
uterus with ovary. Cervix is there or not, you should see. Tube is there or not, you should see. Tube is there, ovary is there, it is there on this side. এদিকে আছে. Okay, so you see, whenever they ask you a specimen, you try to see on the both sides. Okay, ovary with uterus showing a leiomyoma. Okay, what is leiomyoma? It is a smooth muscle tumor. What type of fibroid is this? এখানে যেটা আছে intramural is what type of Figo classification? হ্যাঁ 01 it is 4. Okay, it is 4. If it is touching the endometrium, it will be 3. Then they will ask what type of surgery they have done. কি surgery করা হয়েছিল এখানে? Okay, how do you say it is? Abdominal hysterectomy. No, we can do it laparoscopically also. We can take this vaginally also. We can do this vaginally. So you will say this is a total hysterectomy. What type of surgery they have done? Sir, this is a total hysterectomy. If ovary is there or not, you should see. If ovary is there, ovarian tube is there, you should say total hysterectomy with bilateral salpingo-oophorectomy. Okay, if only you see the uterus, you say it is total hysterectomy. What is subtotal hysterectomy? What are the types of hysterectomy? That is not the type, it is the root of hysterectomy. Radical, modical. নিজের একটা নাম দিয়ে দাও, সাইন হিস্টেক্টমি। Total hysterectomy, subtotal. Radical, extended. Okay, in total hysterectomy you will remove the uterus with the cervix. In subtotal hysterectomy you will remove only the uterus, cervix will be remaining inside. Cervix will not be removed. Okay, in radical hysterectomy you remove the uterus, cervix and upper part of the vagina. In extended hysterectomy you will remove uterus, upper part of vagina and the parametrium. Understood? Parametrium, endometrium এর side, sorry, uterus এর side যেটা আছে, this is called parametrium. This tube, broad ligament, okay, sab bar kora hoyeche. This is extended. Lymph node, that is different. This is only the uterus. I am talking about the uterus only. Okay, these are the types of hysterectomy. What are the different approaches of hysterectomy? Abdominal, vaginal, laparoscopic, then আরেকটা আছে what? Laparoscopic assisted vaginal hysterectomy, LAVH. Okay, in this hysterectomy তোমাদের question আসবে, how will you place the clamps? How many clamps will you place? Both sides মানে কি? clamp 1, clamp 2, clamp 3, clamp 4 এরকম বলো। হ্যাঁ বল তাড়াতাড়ি। হ্যাঁ প্রথম রাউন্ড লিগমেন্ট। হ্যাঁ 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 see first you have to see when they ask you the question, okay, what are the steps of, what are the clamps will you apply serially, okay. If we have to preserve the uterus, sorry ovary, when we are doing only total hysterectomy, okay, so I am not removing the ovary, so I have to preserve the ovary, right na. Ovary is there here, ovary is attached to the ovarian ligament, এখানে IP ligament আছে, this is IP ligament, okay, তারপর এখানে round ligament আছে, this is round ligament, round টা একটু নিচে দিয়ে দিই, okay, this is round ligament, okay. So first clamp I am doing I am cutting the abdomen, okay, I am seeing the uterus. So first clamp what I will do, I will give here, I will take two big artery forceps, I will give here, I will cut here. So what I am cutting, I am cutting the tube and the ovarian ligament, this will be clamp number 1, okay. Then second is this one, what is this, round ligament, this is clamp number 2. Then আমি নিচে আসবো, এখানে there is, what is this, what is this, what is this, আরে এটা কি, this is uterine artery, okay. Third clamp will be uterine artery, fourth clamp will be broad, what, cardinal ligament and McIntyre's and uterocervical, understood. Clamp 1 will be tube, ovarian ligament, clamp 2 will be round ligament, clamp 3 will be uterine artery, clamp 4 will be McIntyre's and uterocervical ligament, okay. When I have to do TA is BSO, clamp 2 round ligament, okay. When I have to do BSO also, total hysterectomy plus BSO, I have to remove the ovary also, what should I do, so first clamp আমি এখানে দেব, clamp 1 on IP ligament, clamp 2 on round ligament, clamp 3 on uterine, clamp 4 on McIntyre's uterosacral, understood. হ্যাঁ ঠিক আছে। Then the আরেকটা question আছে, what are the non surgical management of fibroid হলে আমরা সার্জারি করব না, okay. First we have to do conservative management, then medical management, then surgical management. Expectant management is conservative management, okay. First আমরা bleed, wait, tell me what are the features, clinical features of fibroid. Bleeding, see there is something called milk, okay. M for menstrual abnormalities, I for infertility, L for lump, K for compression. These are the clinical features of fibroid. Either it can cause menstrual abnormalities, it can cause menorrhagia, okay, or amenorrhea, or it can cause infertility. In case it can cause lump in abdomen, it can cause compression. If it compresses anteriorly, it will compress the bladder, there will be difficulty in maturation. Posteriorly, it will compress the rectum, there will be difficulty in defecation. If it compresses the intestine, it will present as acute abdomen, okay. বলো তাড়াতাড়ি, আরেকটা আছে শেষ করি। ব্লিডিং কম করার জন্য ওসিটি বা
tranexamic acid.
OCP tranexamic acid.
Size reduce করার জন্য gonadotropic reducing hormone agonist.
Okay. What is Mirena?
Mirena iron CDO.
What Mirena has? What is the drug?
Progesterone.
What? Arey, what does Mirena have? What Mirena contains what? Levonorgestrel ester. 52 microgram. 52 milligram. Per day it releases 20 microgram. Okay. What is uterine artery embolization? Oh. With this, what is uterine artery embolization?
In uterine artery embolization, there is decreased blood supply, so necrosis happen and then size will be decreased.
ঠিক আছে। ঠিক আছে, দেন ইউ উইল রিড অ্যাবাউট, আজকে লেট হয়েছে অনেক, ঠিক আছে, তোমাদের আরো ক্লাস আছে মনে হচ্ছে। আরে আছে বল না। See, then you will read the complications of fibroid. Okay. What are the degenerations of fibroid? What are the various degenerations? Red degeneration, hyaline degeneration, fatty degeneration, cystic degeneration, sarcomatous degeneration. Are kichu? Okay. Then you will see what are the complications of fibroid. Okay. Tarpor, eta fibroid are Figo classification of fibroid you will read. Everybody they will ask what is Figo classification. What is palm coin? Abnormal uterine bleeding, palm coin. Polyp, adenomyosis, leiomyoma. M for malignancy, C for coagulopathy, O for ovulated dysfunction, E for endometrial causes, I for iatrogenic, N for non otherwise specified. Okay. Then coming to this ovarian. Okay. The given specimen is what? Actually you can't identify. Okay. This is a mucinous cyst adenoma. Okay. In exam if they ask you, you will say this is a specimen of ovarian cyst, probably mucinous cyst adenoma. Then they will ask, how are you saying this is mucinous cyst adenoma?
Very large in size.
Okay, you will say, sir, because of the size, it is a large cyst, thin cyst wall, there is multiloculations, and there can be mucins present. Can be, you can't see the mucin, but if sir asks, you should say, sir, there can be possibilities of mucin. Okay,
Large cyst, thin cyst wall,
multiloculated. There are no solid areas. Okay. What surgery has been done here? এটা কি সার্জারি হয়েছে এখানে? এরকম দেখে তুই যদি না বলে না, কি হোয়াট সার্জারি এখানে কি আছে? Ovary আছে. So what surgery has been done? Just an oophorectomy. Okay, sir, you should see if there is tubes and ovary, sorry, uterus is there or not. Uterus is not there, tube is not there, so there is only oophorectomy. Okay, then they will ask you, could we have added any other surgery here? Should have we done any other surgery here? Cystectomy you will decide based on the age of the patient. If the patient wants fertility, because the ovarian cortex, no, ovarian cortex আছে, ভিতরে medulla part আছে. Okay, this cortical part is more important for the fertility. এখানে ovary ওই যে ovum গুলো produce হচ্ছে না, that will be from the cortex only. Okay, so when there is a cyst, if you just remove the cyst, baki thing is preserved. This you will prefer only in unmarried patients or in patients who want pregnancy. Okay, if pregnancy is completed, you need not preserve. You can do oophorectomy only. But I am not asking that. What extra surgery should have been done here? There should be salpingectomy also. we should remove the tube also when we are removing the ovary. Salping or oophorectomy. Why should we remove the tubes? Shivam Bol. Why should we remove tubes also? नहीं पता है क्योंकि इधर कार्सिनोमा ओवरी हो रहा है ना, सीए ओवरी का इनिशियल पार्ट इज फ्रॉम द ट्यूब ओनली. फेलोपियन ट्यूब्स से माने जो सेल है it will go inside the ovary and it will initiate the carcinomatic process. Okay, so we have to remove the tubes also whenever we do oophorectomy. Then you should see what are the differences between benign and malignant cyst. Okay, there will be ascites, bilaterality, if solid cyst. What's ovary? अरे আমি যেটা বলছি ডিফারেন্স বিটুইন benign and malignant, কি কি ডিফারেন্স আছে ওগুলো দেখে নাও. What are the benign cysts, what are the malignant, মানে classification of malignant ovarian cancer, germ cell 6 cord cells tumor মানে টিউমার কি কি আছে. Okay, epithelial cell tumor কি কি আছে, that everything is theory. Okay, what is dermoid? Okay, where is dermoid arrived from, what is মানে কি কি features আছে. Rokitansky protuberance. Okay, how will you differentiate between ovarian mass and the fibroid? This will be the last. Okay, after this we are finishing. Room जाके सो जाना. Anything. How will you differentiate? When I ask you, how will you differentiate? You will start from history. What the patient is saying, history, clinical features. Then you will examine the patient, inspection, palpation, percussion, pervaginal examination. Then you will come to the total diagnosis. So from history, fibroid hole ki hobe, uterine mass hole ki hobe, mane ovarian mass hole ki hobe. If there is fibroid, there will be that milk symptoms. Okay, any of that will be there. If it is an ovarian mass, what will be there? Mostly there will be lump in abdomen. Okay, and the lump will be mostly towards the periphery because ovary is on the side. Unless if it is a big cyst, it will be on the periphery. If it is because of the fibroid, it will be mostly confined to the midline. Okay, then it will cause bleeding, it will not cause bleeding. Ovarian cyst can cause bleeding. When? Pervaginal bleeding. When can ovarian cyst cause pervaginal bleeding? No. If the ovarian tumor is producing any hormones, okay, if it is producing estrogen, progesterone, then it can cause vaginal bleeding. What are the hormonal producing ovarian cancers? This will be your homework. Okay, this question definitely they will ask. What are the hormone producing ovarian tumors? Leydig sertoli cell tumor, okay, granulosa, androblastoma, arhenoblastoma, okay, these all will produce hormones. Then parabdominally, if you see, it will be lateral, it will be medial. Okay, and there will be a cleft in between. If there is a cleft in between, it is ovarian. Okay, if the cleft is not there, it is fibroid. Okay, and when you move the what? আসতে পারে, but mostly ঠিক আছে, সিস্ট বড় হলেও তো সিস্ট মানে ক্লেফট বুঝতে পারবি না. ঠিক আছে, দিস ইজ ফর মিডিয়াম স্মল সিস্ট. rough idea. And pervaginally when you move the uterus, আমি পিভি করছি, সার্ভিক্স আমি যখন মুভ করছি, If fibroid is there, it will move along with the uterus. Ovarian mass will not move.